Okay, single leg. All right, what are you guys getting? Ankle, knee, back. I think the hair moved too. Okay. Okay. So rotating, so from this angle we're getting trunk rotation, right? So we have a lumbar rotation give. What are we getting from the front? Go ahead. So now, so are we seeing a leg valgus? Are we seeing the knee valgus?
Yeah.
That was just one way to get there. How did we get there?
No, it's okay.
Yeah, she went. So there was a whole pelvic shift, and then the knee went, and then there was a bit of a correction. Okay? So this will be fun. All right, so I'm going to come in the front of the hip. Is that okay?
Yes.
Okay, ASIS, below the inguinal ligament on the inside of the rec fem musculature, using finger pads to hug the front of the head of the femur. I'm putting my hand on the acetabulum, trying to avoid disrupting the weight shift. Okay, I do a little shake to let everything relax a bit. Yes, it's a biomechanical correction. I'm going a little rogue by using some Clinet 2 strategies. Okay, now you're going to weight shift towards me, and single leg, and squat. A lot of side bend in the trunk? Okay. Okay. Now, so let's, you okay? Did that hurt?
No.
No? Okay. All right, I'm going to try external stabilization of the hip. Okay? I'm going to come in here. Yes, very rogue. Okay. Now, what I want to do is, as you squat this time, you're going to think about sitting back into my hand. So weight shift first, lift your other leg in the air, and sit back. Okay, come back up. So much side bend and rotation. So we're kind of inclined to go to the pelvis, aren't we? Mm-hmm. However, it's hip and knee day. So we didn't get to the knee yet, but let's play around with the knee. Okay, feet even. So soften your knees for me. Is that pressure okay?
Yes.
Okay. Now weight shift. And now go ahead and squat. More rotation? More trunk rotation? How did the valgus do?
Valgus was a little better.
What's that?
Go to the ankle.
So actually, I'll only do another.
Wait, sorry.
Let's take a leg.
Are you giving external stabilization to the knee? Is that what you're doing?
So I'm doing a bit of a biomechanical correction.
Okay.
I'll explain it in a second. I just wanted to see if we could get a good response. You okay?
Yeah.
Okay, weight shift.
That felt like the best one.
How did the trunk look? So still a rotation in the trunk? Okay. Okay.
But I think that's just because it's hard. It's a one-legged squat, or no?
We still, I mean, you're allowed to weight shift, but we shouldn't have so much of a side bend give. So let's go up to the pelvis.
He's like, I need to try it anyway.
Okay, single leg.
I don't know, though. I think your knee got better.
Less
Yeah.
valgus, the trunk look.
Trunk is better.
Yeah, I'm still not. I'm not convinced that.
Roll away from
Put my hand on your platform. Definitely the TMJ. Okay, one legged.
No, why? Oh, what that was.
We definitely got a good merengue going there. Okay, put your feet even.
Sorry.
Bend
Should
your
she be
knees.
fatiguing at this point too, or no?
Yeah, sure. Yeah, she's got it.
She's like, just stop.
You got it.
I know.
Okay, let your knee come out to me. Relax. Come out. Okay, now weight shift.
It's okay. See, that's the best.
That felt good.
Now look at it.
That was better.
Okay.
Only really.
So we are getting some fatigue, but from this, where are we thinking the driver is? The knee. Okay. Is it perfect? No. But what you saw me do is do biomechanical correction at the knee. So the different gives that can happen. If the knee goes into knee valgus, then the knee can shear medially. So what I'm doing is I'm actually inducing a lateral glide to the femur. So I'm gliding her out. The first thing I did was a rotation glide. So I tried to do rotation different directions. I wasn't getting good control. But when I brought her into a lateral glide of the femur, that was when I started to get the best correction. Now that makes sense because part of what's happening is she's dropping into an anterior medial laxity in her collapse. So I'm essentially supporting that. If I were to do, and we'll do in Clined, you're going to do just the external stave. That looks like this. Put your feet even. Okay, I'm going to come in and I'm just going to give a little, bend your knees for me. Okay, and now go ahead and squat. Do a single leg.
Single leg. I'm gonna sit on you.
Alright. How did it look? So it wasn't enough.
Like you could have started with that. and then gone out.
I easily could have started with that, but I wanted to do biomechanical correction because we're in MS1. Right?
No, yeah,
So-
I'm saying like, yes, clinically, then you get better and you do the next one.
Yep. Yep.
I know we're not doing ankle yet, but it looks like a lot coming just from her imbalance, like to be able to stand
Yeah.
on one foot too.
All right, let's take a look. I almost went there, but I'm more convinced it's the knee than the knee. The reason the ankle is going to help is because of the fibula. Yeah. Okay. Single leg. Less valgus. Pretty good. All right. Feet even.
Are you doing rotation or lateral glide at the knee?
Oh, that's a
Lateral glide of the knee. Biomechanical correction at the ankle.
Lateral off the
Whoa. Okay, now go.
It's a winner.
So it was a double correction. All right, so giving her support at her foot and ankle and biomechanical correction at the knee, that was the best. Okay? Why does that make sense?
interdependence.
Interdependence. And specifically here, what kind of interdependence are we looking at? Yeah, lower extremity, but what is all of this? Kinetic chain. So it is the regional interdependence, but so is this. But what we're getting here is the lower extremity kinetic chain. The lower extremity valgus, bad name. The knee valgus, still not a good name, but this is how they describe it. What does that involve? Hip internal rotation and adduction. What does that involve in the knee? Knee valgus, tibial external rotation. What's happening at the foot? Pronation. Okay? So if I do a biomechanical correction and pull out of pronation, I do a biomechanical correction, I do a lateral glide of the knee, so I'm preventing that medial buckle. I support both of those, and now you go through, and that helps the best out of anything. Okay, there's still other changes. So is that the side?
Yeah.
Okay, so what do you have going on that knee?
Well, I had ACL surgery, but I had a subchondral fracture, had MCL sprain, and 2 meniscus tears. Both, they cut both.
Okay. All right, how long ago did you have the reconstruction?
2010,
Okay.
and then I played like 6 years of softball after that.
Okay. Did you re-injure recently?
No, it's just always been bad.
It was bugging you. Wasn't bugging you.
It was good until I like overused, like I
Good
played
until I
all the
kept
time.
squatting on that one leg.
Yeah, over and over for some demoing lab. Yeah. Okay, so there are interesting findings here and a very interesting history. So we would want to continue with the breakout and kind of assess things a bit further to figure out where to go.
As far as clinical priority, what would you target more?
Well, we definitely start at the knee.
Okay.
Yeah, but probably her retraining would go foot and knee pretty much right away. But that would be where we would start.
And because the biomechanical correction worked, your non-break, you'd move, I'm saying, so then you move, if I'm thinking of like a non-functional breakout, well, you need to assess the joint, right?
Absolutely.
Obviously, you know now you need to assess the joint.
Yep.
And then we can move on to a non-clinical.
Yep.
Just thinking.
Yeah, that's exactly where you should be thinking, because that's where we would go from here. We want to figure out if there's something we can do to help this knee, set the environment up so that her exercises can be more successful. And the site to go to is her fib head, so the superior tib fib joint. If we help to work on that, that's going to be able to allow that knee to abduct better. All right, but we're going to get into that in a moment.
I do get the most pain actually right here.
Yeah. So, yeah, what's that?
Was your osteochondral kind of associated with your ACL, or was that prior?
No, it's associated with. They told me to go back to get a check, but I never did.
Well, look at that.
Okay, so we have stools. Yep.
Dove on it.
Did you do a one-legged squat, kind of like if you just kind of just dropped your, like if you were doing a back lunge like that? Or
So
does
there
that
are
take a
different
lot?
ways you could do the one-legged squat, absolutely. And it would change the impact for depending on the position of your leg. So that's kind of up to your clinical priority, what you actually want to do. I'm generally just doing one-legged squat with the right leg out of the way, like this. Okay? Yep.
Oh, no, and so I